Testing, testing, testing. All right, for chapter 11, a lot of this, there are going to be different things we'll talk about in here that we have actually already covered quite a bit about. So I'll go through those quickly and just point them out in your slides. But this chapter is about neurodevelopment disorders in childhood. So a couple of things you want to know about: 75% of adults diagnosed with psychiatric disorders were first diagnosed between ages 11 and 18. Um, Disruption to family function and stigma plays a big role in this. The reason for that is because, we tend to look at children with psychiatric disorders as having behavioral problems versus actually having disorders themselves. And then in your book, it talks about a lack of services and premature termination of treatment are two of the main problems, especially for vulnerable populations. So the diagnosing and the discharge from help happens too quickly. The difficulty in diagnosing younger people, because our younger people have limited language skills and cognitive emotional development. I've seen this in my own life with my third daughter who has ADHD. And we've had significant testing done on her to come to the realization that it definitely was that diagnosis. But as she was 3 years old when I could tell something wasn't right, that something was much different with her. But as a mother, you tend to be, or a parent, you tend to be more in tune with that than your doctors and your healthcare providers. And then lack of services and premature termination, which we already talked about. The vulnerable populations, people, the kids that live in poor areas, single parents, that type of thing. And then the stigma again that this is just behavioral issues. So your etiology, your genetics play a factor. Actually, with one of the psychologists that I met with said that for children diagnosed with ADHD, one of the parents usually has it at some type of level, maybe not severe, but it typically comes from a family member. Neurobiological, so brain changes during childhood and adolescence. Your book says that the synapses in the brain peak at age 5 and then begins to decline after that. Early adolescence characterized by low emotional regulation and intolerance for frustration. So we've all seen that if anybody's had a teenager or been a teenager, obviously. There's not a big tolerance for frustration during those age years, and emotional and behavioral control typically increases through the years of adolescence. Temperament, which we've talked about already in class, but in your child is the behavior that the child uses to cope with the demands and expectations of their environment. So if you've had a lot of traumas as a child, of course, this is going to be, a temperament that we may see. And right below, you'll see aggressiveness, rebelliousness, predictors of substance abuse, which we've talked about all of that, and seen that in the clinical setting for both our psych patients and our substance abuse patients. Many of them have had abuse in their life as a child. And then resilience, which we've talked a lot about, and then just your different things with resilience. Make sure you read through that and resilience, but most of you already do because we've talked about it so much. Environmental factors, so trauma may be detrimental to developmental periods. So severe marital discord, low socioeconomic status, large families and overcrowding, maternal psychiatric disorders, foster care placement. Neglect is the most prevalent form of child abuse, which we've already gone over that. 1.7 million reports of child abuse in 2010, and there's your breakdown below it. And nurses are required to report suspected abuse. Assessing developmental and functioning. Assessment data, agency policies typically determine what data will be collected. So it'll depend on what kind of area of nursing you're in, and if you're working, like for instance, in some type of community setting that works with children, what kind of assessment data would be taken during that. So the rest of this stuff, you're not going to need to know as far as the test is concerned. We will talk about play therapy a little bit in just a little bit, but I won't ask you anything about the Denver 2. I'm sure you had enough of that with your peds. General interventions. So we have our family therapy, group therapy, behavioral therapy. And so with behavioral therapy, much like our psych patients that we talked about before with that are inpatient, the least restrictive intervention to ensure civil and legal rights. Remember that even patients with mental illness or and children all have the same civil rights as everybody else that comes into any kind of care setting. Cognitive behavioral therapy, disruptive behavior management, so seclusions or restraints. Physical needs must be assessed. You must make sure that you're always checking your patient for if they need water or food or they need to use the bathroom anytime we have them in seclusion or restraints. And then timeout and quiet rooms. I know those of you at Hurley probably are seeing what quiet room therapy looks like. At Brighton, you don't, but I know in most locked psych units, they do have quiet rooms for their patients that are acting out. So your general interventions, play therapy, that's a good one where the children can sit down and play with different toys and express thoughts or emotions. This is something that, especially if you're working in the pediatric area and for children that have different issues or mental health problems, that they may use play therapy instead of trying to talk or have a therapist talk to them. Bibliotherapy is literature to express feelings. Therapeutic drawing, illustration of thoughts and feelings that they're unable to express. And this is really another good way, too, even with your own kids, to have them draw a picture because a lot of times kids will show exactly what they're going through in their drawings. And then we have our music, our pharmacology, and teamwork and safety. Speech disorders, so this is problems making sounds. So a lot of us may have had children or no children that say no for snow or lello for yellow. Language disorders, difficulty understanding or using words in context and appropriately. Inability to follow directions. Expressive language disorder, inability to develop skills to communicate verbally or through sign language. And that would be very difficult for the parent and the child because they're not able to speak or to sign to the parent to let them know what they need. And 6% of all children have some sort of communication disorder. And then our three learning disorders that we have here are dyslexia, which is, reading, dyscalculia, which is math, and dysgraphia, which is written expression. So the lifetime prevalence of a learning disorder is 10%, and learning disabilities account for the largest percentage of children receiving special education services. And any of you that have had a child or know a child with an IEP, this is exactly where that is falling under. Motor disorders, your stereotypic movement disorders. So this is repetitive and purposeless movements. So hand waving, rocking, head banging, nail biting, teeth grinding for a period of 4 weeks or more. These children may end up having a helmet that they have to wear for their head protection. And naltrexone is a drug they have found that may block some of the euphoric responses that come from these behaviors, so that'll reduce the occurrence. And then Tourette's disorder. I know one student got to see a patient with Tourette's with me. It's usually familial, about 90% of cases. Motor tics, which is typically the physical. And then the coproplalia is uttering obscenities, which is what we think of when we think of Tourette's, because that's how it's been portrayed in movies and society. But this is actually only in fewer than 10% of cases where you actually see that. Intellectual developmental disorder, this was previously called mental retardation. So deficits in intellectual functioning, social functioning, managing age-appropriate activities of daily living, school and work, performing self-care, and the incidence is only 1 to 2% of the population. Neurobiological disability, developmental disability, these usually appear during the first 3 years of life, is 4 times more common in boys. Deficits in the following areas, you can read through those, and other behaviors, you can read through those as well. So with attention deficit hyperactivity disorder, or ADHD, It's an inappropriate degree of inattention, impulsiveness, or hyperactivity. They actually have this broken down into a couple different categories now, because they no longer use the term ADD. It's all ADHD with a certain type. So some of it's just the inattention, some of it's the impulsivity, some of it's hyperactivity. It's most often detected when difficulty in elementary school occurs. So they have low frustration tolerance, temper outbursts, labile moods, poor school performance, peer rejection, low self-esteem, hyperactivity, difficulty taking turns in maintaining social relationships, interrupting others, distracted easily, disorganized, unable to complete tasks, lose things easily, and require frequent prompts. And much of this describes the child that I have that has ADHD. Medication has certainly helped, but one of the telltale signs that one of the doctors we saw had said is give the child 3 tasks to complete and see how many they get done. And what we found for our daughter was that she couldn't even get through one typically, and she forgot about the second two. Oh, whoops, I went too far. I missed that last slide there. Um, so ADHD continued, boys have twice the rate of incidence than girls. Your box 11.3 on page 195. That is your techniques for managing disruptive behaviors. Make sure that you read through those and know those. That there may be a couple of questions on the test from that. And your drug treatment for ADHD. Your Ritalin and Concerta, those are probably your 2 biggest ones used. I would say, well, an Adderall as well. But I'm not going to ask you specific drug questions about for ADHD. So, which child would be most difficult to diagnose for a neurodevelopmental disorder? And that would be your 3-year-old. And a 4-year-old frequently lashes out in anger at adults and other children. This child's style of behavior is an aspect of, and that would be their temperament.